All right, we're about to kick this off, and I would like to start by saying good afternoon to everyone and thanking all the participants for making the time to be here today. My name is Foyeke Oyedokun Adebagbo, and I work with USAID Nigeria. I work with the Health, Population, and Nutrition Office, and I work as a social behavior change program manager, and I provide direct management support to Breakthrough Research, who are the organizers of this webinar. So I'd like to say thank you for joining us. Thank you for making the time. I thought I would use the opportunity of this very quick introductory remarks to provide a very quick overview of the Health Office of USAID Nigeria's social behavior change programming portfolio, but also whet our appetites a little as to the types of information and data that we would be hearing and learning from as a result of joining this webinar today. We have a list of amazing presenters lined up, as you would see on the introductory slides, which I'm hoping you can see on the screen right now. We have colleagues from the Chief of Party from Breakthrough Research Nigeria. We have a Deputy Project Director for Breakthrough Action in Nigeria, as well as Paul Hutchinson, who is also of Tulane University, one of the partners on the Breakthrough Research project. So to start off, I think it would be really preaching to the choir to say that for us to really improve health outcomes, we need to improve the quality and we need to do more than just improving the quality and coverage of our health products and services. We need to invest in programs that require change, that help us to change health-seeking behaviors of individuals, of communities, that help us to address some of the underlying factors and norms that drive these behaviors. And it is with this very simple but really solid rationale and logic that USAID has continued to invest in social behavior change programming for over decades now, for several decades now. Particularly the USAID Nigeria Health Office has bought into two flagship USAID social behavior change programs, and these are Breakthrough Action and Breakthrough Research. And both programs are designed in a way that really are in support of Government of Nigeria's health promotion policies, several reproductive health and maternal and child health and family planning policies, strategies, and guidelines. As the names imply, Breakthrough Action is that mechanism that deploys the existing evidence, deploys proven interventions and tools and resources to implement programs that increase the practice of priority behaviors across different health areas, so maternal and child health, family planning, nutrition, and malaria to be specific, and TB. Breakthrough Research is the other word or mechanism. We'll be learning a lot more about Breakthrough Action in the course of this webinar. Breakthrough Research complements Breakthrough Action's programs by generating and providing data and evidence, new evidence, that would help us improve our social behavior change programming. As you would agree with me, there's a lot that we need to learn in the social behavior change programming space, and Breakthrough Research is that very vital mechanism that helps us to generate all the data and all the evidence that we need to continue to learn, to adapt our programs, but also to contribute to the body of knowledge of what works and inform future investment in social behavior change. So as you would be hearing later today about one of the biggest research endeavors that Breakthrough Research is undertaking in Nigeria, which is the Behavioral Sentinel survey. While it is true that this survey is fielded in Breakthrough Action Program areas, it's important that the reason why we're convening this webinar today is because we know that the compelling evidence and the wealth of information that was collected would be useful to so many people as well in thinking through their own programs and their own investment, and even in thinking through some of the policies that we potentially have right now. So we'll be learning a lot more about the methodology and the specifics of the Behavioral Sentinel survey, but to note that this is, we envision that this would be in a three-part series, so a baseline, a midline, and an endline. And this is the result of the baseline, which was fielded in late 2019. It collected a wealth of data, as you would see, on social, cognitive, and emotional determinants of behaviors, or what we would call ideational factors. and it definitely is going to contribute immensely to the body of knowledge. So at this point, I would like to encourage you to listen with rapt attention to our vast presenters as they walk us through this amazing wealth of information. And hopefully by the end of it, we would have validated some of the things that we already know works in social behavior change programming to change some of the behaviors that seem intractable to change, but that we would also have learned new things. We would have unlearned some of the old things that we thought were, important, but turns out evidence is telling us are not as important. And we hope that you would come off with a different perspective as to how you would approach your programming going forward. At this point, I would hand you over to, I think, Dele to kick us off with the presentations. Over.
Thank you very much, Fuik. As you have heard, Fuik is our activity manager, and we are very excited to have her to introduce today's presentation. My name is Dele Abegunde. I'm the Chief of Research in Nigeria. I also have with me in the background, but we'll be doing most of the responses. Is Emily Johansson. She's the Deputy Chief of Party for Breakthrough Research in Nigeria. Presenting with me is Shitu Abduaguye, the Deputy Project Director for Breakthrough Action Nigeria, and we have a principal investigator on this study, Paul Hutchinson, who is a prof in the University of in Tulane University, and he leads the technical work on the Breakthrough Research Nigeria. Next slide. Presenting our evaluation of integrated versus vertical SBS programming in the northwestern part of Nigeria, specifically with in Zamfara, Sokoto, and Kebbi State. The results are exciting. We presented them before in a global meeting with a lot of exciting response to the results. And this is our national, we're beginning our national presentation series, and this is the first in the series. The objective of the presentation today are to demonstrate the behavioral sentinel surveillance survey can be used for informing Breakthrough Action Nigeria and the wider SBC community, not only in Nigeria, but globally, to provide data for assessing the integrated versus vertical SBC programming, to measure the influence of ideation metrics for material newborn and child health plus nutrition in Nigeria, and then to demonstrate the potential effectiveness of social and behavioral change programs, and finally to discuss the planning for the future. Next, please. As you have been told, Breakthrough Research is a USAID's flagship project for social and behavioral change, change research and evaluation. It's a five-year project that began in August 2017, and we extend to July 2022. The Nigerian activities started in January 2019. The office was established and opened in September 2019. We work in cooperation with our sister project, Breakthrough Action, who are the SBC implementing partner in Nigeria, and we are supporting Breakthrough Action research, bringing evidence, programmatic evidence to advise breakthrough action as they implement their programs. Next, please. Breakthrough research is a consortium of institutions, the Population Council, which is the lead in the consortium. The Tulane University leads the technical aspect, the research and the analysis aspect. Avinia Health also leads the costing and cost effectiveness analysis aspect of our research. Ideas 42, Population Research Bureau, and the Institute for Reproductive Health in Georgetown University. Next slide, please. Will embed rigorous research within a state SBC programming in Nigeria led by Breakthrough Action. And if you look at the hexagon there, you see about 6 different areas of research that hooks with Breakthrough Action XBC program in Nigeria. We have the effectiveness evaluation of integrated versus malaria-only SBC programs and behavioral Sentinel survey, which we call BSS survey. We also have the costing study and the cost effectiveness study evaluation of integrated versus malaria-only SBC program using BSS results and program cost data. And we have a series of qualitative evaluation of specific SBC program components, e.g. the sustainability model. Today we are listening to the results from the BSS survey. Next slide, please. The BSS survey is designed is a 3-flank survey: the baseline, midline, and the endline. We'll be presenting the baseline, the result of the baseline survey today, and the results and from this speaks very strongly and contributes to national priority and goals, particularly the National Health Promotion Policy Objective 2, which is facilitating health promotion interventions to support government efforts aimed at ensuring sustainability, health behavior, healthy lifestyle, and enabling an environment, and so on. The action point under this objective is promoting positive behavioral measures to improve maternal, newborn, childhood health in Nigeria, improving child care practices, which includes uptake of immunization, exclusive breastfeeding, and additional or complementary feeding. Next slide, please. At this point, I want to invite my colleague to take over from this, to explain to us from the point of view of the contribution of Breakthrough Action to this work.
Okay, thank you, Dele. Good afternoon, everyone. My name is Dr. Shitu Abdu Aguye, Deputy Project Director for Breakthrough Action Nigeria. Next few slides, I'll take you through a quick overview of the Breakthrough Action Nigeria project. Breakthrough Action project is USAID's flagship global SBC project, which has a presence in more than 28 countries around the world. We have the same duration as breakthrough research from 2017 to 2022. The goal of the breakthrough action projects, we work closely with the federal and state Ministry of Health, programs departments, and USAID IPs to increase the practice of priority health behaviors in the area of malaria, maternal, newborn, and child health, including nutrition, family planning, reproductive health, and tuberculosis. We have 3 intermediate results. The first one is to improve individual and social determinants of health to facilitate individual and household adoption of priority health behaviors. Secondly, we were working to strengthen monitoring, coordination, and quality of SBC across USG investments. And thirdly, we're working to strengthen public sector systems for oversight and coordination of SBC at national and sub-national levels. Next slide, please. Now, working with 17 priority behaviors, I mean, that's a lot of behaviors to juggle, particularly when you're trying to address social behavior around these behaviors. So we categorize these behaviors using milestones or life stages. This slide shows some of the milestones we initially were working with, from pre-pregnancy through pregnancy, childbirth, first 6 months, up to 2 to 5 years of age. Operationally, we actually work with life stages. We have 4 life stages that we use to actually implement SBC activities in the field. The first life stage is pregnant women in early pregnancy in the first 6 months. Second life stage 2 is pregnant women in late pregnancy, 7 months to first month after delivery. Life stage 3 is caregivers of children under 5 years, and life stage 4 is couples of reproductive age who are not currently pregnant. So this is how we approach the audiences that we address with our SBC interventions. Next slide, please. Breakthrough Action Nigeria uses a coordinated multi-channel approach for our SBC interventions. There are 5 main components of that approach. The first one is the community mobilization approach, which consists of community SBC, which is more of the direct demand creation activities, and community capacity and sustainability activities, which is around building the capacity of community structures to plan, implement, and monitor activities for improving the health of their own communities. We have the secondly, the mass media activities. This is where the Albishirinku video drama comes in. Albishirinku is a theme for SBC activities in the northern states, which you'll see shortly. The Albishirinku radio drama uses a unique format, 5-minute episodes daily, where different characters who have a role to play or influence on priority behaviors are featured and addressing different behaviors that are pertinent to the episode at hand. We have the mobile digital activities, which are cross-cutting across most of DA Nigeria's activities. Most of the mass media materials are actually domiciled Airtel 321 platform through a partnership that the project has with Airtel. And the mobile digital approaches are getting a lot more significance in this era of COVID-19. Fourthly, we have advocacy activities working with religious, traditional, and opinion leaders to address gender and social norms, social and gender norms at community level that have impacts on practice of the priority behaviors. And finally, we have a provider behavior change activities. We address providers' ability to use malaria guidelines and to implement full maternal care. We have several approaches that we use under the provider behavior change. Next slide, please. Breakthrough Action Nigeria works in 11 states plus FCT, making 12 altogether. There are some states that are just implementing an integrated approach. These are Bauchi, Sokoto, and Kebbi at the moment. Then other states that implement the vertical malaria-only SBC activities. These are Zamfara, Nasarawa, Benue, Ebonyi, Cross River states. And there are a few states that implement malaria and FP together. These are Plateau, Oyo, and Akwa Ibom. This distribution is evolving. FCT and states will be taking on integrated activities in the next couple of weeks as we proceed with the projects. Next slide.
Okay.
Thank you.
All right. Thank you, Chitu, Dele, and Foye. I'm Paul Hutchinson of Break Research and Tulane University. And so I'm going to talk to you now about the specifics of the BSS and some of the results that our team has to date and what we plan to have over the rest of the year and the rest of the project. As Chitu was saying, the data collection took place in 3 states, Kebbi, Sokoto, and Zamfara. Our study populations for the BSS were currently pregnant women and women with a child under the age of 2 years. These populations correspond to the main life stages focused on by Breakthrough Action. Specifically, they focus on the priority 1,000-day window from pregnancy through the first 2 years of life. As I said, we collected data in states, but the data are only representative of BA program areas and not of the states themselves. The study design involves both cross-sectional and cohort components. So to provide estimates of the prevalence of behaviors and ideations over time, we use repeated cross-sections of women with a recently completed pregnancy at 3 points in time, both baseline, midline, and endline. And we're also using a cohort of pregnant women at the time of the survey to document their 1,000-day window experience. There's a quasi-experimental component to the evaluation in the sense that we're comparing geographies with integrated programming, so Kebbi and Sokoto, relative to those with vertical programming, meaning Zamfara. There's also a dose-response component in the sense that BA is implementing 2 types of integrated programming. So specifically, we randomized 72 wards in integrated areas to receive either a standard dose of SBC activities with a set number of household visits by community health workers and a set number of community dialogues and so on, and another 36 wards to receive high-dose interventions with a greater intensity of household visits and community dialogues. Our sample size includes over 3,000 women who were pregnant at the time of the survey, which represents a complete census of pregnant women in the survey clusters, and 3,000 women with a recent pregnancy. And because this latter group was more numerous, we collected a random sample of those. We collected data in a total of 108 wards, which is 36 wards per domain, 36 high-dose integrated, 36 standard dose integrated, and 36 vertical. In the presentation today and in the baseline survey report, we present univariate and bivariate analyses by state, by wealth, by education level, by ideational factor, and so on. And we're also presenting today mixed effects logistic regression results linking ideational factors to behaviors. So why is the BSS a rich source of data? So first of all, there are a lot of ideational metrics that you'll find in the literature related to knowledge, attitudes, behavioral control, and intentions for health areas such as family planning and malaria. But there's been less done in the literature for other areas such as treatment-seeking behaviors for childhood illnesses and childhood immunizations and so on. And it's important to have this kind of information because the theory of strategic communication and behavior change in which breakthrough action it's the foundation for the investment in breakthrough action, both in Nigeria and globally. So it's important to test these underlying relationships between ideational factors and behaviors. Secondly, we're using the BSS to track these priority indicators over the life of the project to see just how messaging is having effects on behaviors in both integrated and vertical states. And moreover, by collecting this detailed information, we can estimate the magnitude of effects for different barriers and influencers to behavior change. So by doing so, we can identify which influencers, such as knowledge, beliefs, values, self-efficacy, and influencers, seem to have the largest effects on behaviors. And thereby, we can identify which areas should be priorities for messaging. So today, we're going to look at programmatic questions in 6 areas. The first is use of services, and we want to look specifically at the prevalence of the 17 priority behaviors and the prevalence of ideational factors such as knowledge and beliefs. We also want to look to see if there are certain myths or incorrect beliefs held by respondents that could impede the uptake of key behaviors across health areas. We will look at perceptions of health services and any other barriers that they may face in accessing services, such as cost, distance, and disapproval. We look at household decision making. For example, who influences healthcare decisions? Is that influence positive or negative? And how much autonomy do women actually have? We will then, using regression analysis, look at how important in a statistical sense are different ideational factors. And then finally, using those regression estimates, we will model how much SBC could affect these behaviors in an idealized world, knowing that we're unlikely to have a situation in which everyone has perfect knowledge or everyone is perfectly capable of getting to a health facility. And from that, we can get a sense of just how far SBC can get us. So I've been alluding to this so far, and this is the theory of strategic communication and behavior change, which posits a pathway from exposure to communication activities, in this case, the mass media advocacy and community activities of BA, as Chitu was describing, through 3 ideational domains and 9 ideational subdomains, leading to changes in intentions and behaviors. So in our questionnaire, we had survey questions that were intended to measure as many of these domains as possible across all of the 17 priority health behaviors. So if you figure we have 17 core behaviors and 9 subdomains, that's a minimum of 153 questions to get a comprehensive look at all of the drivers of all of the priority behaviors. In reality, we had many more questions than that, probably over 300 ideational questions. And even then, it wasn't as comprehensive as we would have liked, but we faced a trade-off between being comprehensive and risking respondent fatigue that would jeopardize the overall quality of the data collection. Our questionnaire was developed jointly with Breakthrough Action and with the input of outside experts. A lot of questions came from previous survey work that we've done and has been conducted in previous USAID projects and in the DHS, for example. And we prioritized questions based on their programmatic importance. So by way of an example, we can look at the childhood immunization questions that were included in the survey. And a lot of these came from the WHO vaccine hesitancy work and other sources. We also vetted these questions with immunization people within USAID. And so we followed this process, an analogous process for not just immunizations, but for all of the priority behaviors. So in terms of questions, we would try to have a question for each of the specific domains. Okay, for example, for knowledge, we asked at what age should a child go for his or her first routine vaccination? And then we would code that data for analysis as those who provided correct answers versus those who provided incorrect answers. For beliefs, for example, we had questions such as how effective are childhood vaccines, and agreement with statements such as vaccines have chemicals that can be dangerous to a child's health. And you can see how we continue across the various ideational domains until we have a complete framework by which we can assess which factors, which domains are most influential for a particular behavior. So we have a lot of information in the baseline survey report, and I encourage people to look through that to get more detail on the study and the results of the study. We can't cover everything today. The baseline report describes the underlying strategic communication framework, the rationale for the study design, the study methods, and obviously the study results. It summarizes over 500 indicators across all 3 states, integrated and vertical, and it estimates standard DHS indicators for behaviors such as antenatal care use, facility deliveries, childhood immunizations, breastfeeding, use of insecticide-treated nets, and a variety of others. So in the area of use of services, so here are prevalence estimates for 6 key behaviors by state, and the integrated states are in green and the vertical state is in blue. And the first thing that you should notice is that the prevalence of all indicators is quite low. You may notice that none of the vertical axes of these graphs exceeds 50%. So for none of these behaviors do the majority of women engage in them. So that's an important thing to note. The second thing that you should notice is that there are variations across states, and in some cases, the MNCH indicators are better in the vertical state relative to the integrated states. And so the blue states, or the vertical states, won't have much BA MNCH programming, and so we wouldn't expect much change in these blue bars over the course of the project. But these integrated states will receive MNCH programming, and so we would expect changes in these green bars. So by the end of the project, we expect the green bars to be higher than the blue bars in all cases. And finally, you may notice that certain indicators, such as immunization rates, are very low across all three states. So we looked at various indicators by geography to see if there were any clear patterns. So here are our three states: Sokoto in the north, Kebbi, and Zamfara. And then we categorized LGAs, and noticed that these white areas are LGAs where there are no BA activities, and so we didn't sample there. We categorized these LGAs by what percentage of women engage in a specific behavior. So red for less than 10% prevalence, and green for 40% prevalence or more. And the first thing you might notice is that in each state, there is considerable variation. You can find green high-performing areas in each state and red low-performing areas in each state. For some indicators, however, there appear to be pockets of consistently low behaviors. In this case, exclusive breastfeeding practices in Southwest Kebbi. And then finally, for some indicators, such as vaccination rates, all geographic areas seem to be performing at equally low levels. So again, we have three behaviors. Facility deliveries, in this case, also show considerable variation both across states and within states. Formal care seeking for diarrhea is fairly good. More than 40% of children on average are taken to a formal sector provider for treatment with diarrhea. You can see all of the green across these states. Okay. However, for treatment with ORS and zinc, again, we find variations both within states and across state, pockets of poor performing areas relative to areas with better performance. So the data highlights some common practices that may inhibit the uptake of priority behaviors. And all of these factors are statistically significant in regression analysis when we're looking at factors associated with uptake of behavior. So for example, for pregnancy and childbirth, we know that only about 4 in 10 women make any ANC visits, and among those, more than 2/3 did not discuss a birth plan with a healthcare provider, which is going to be a BA priority during the project. Second, for exclusive breastfeeding, it is fairly common practice for women to provide liquids other than breast milk soon after childbirth because there's a belief that colostrum is bad milk. Again, we see variations across the state. So this means that 6-month exclusive breastfeeding rates are never going to get very, very high if the majority of women think that it is bad to exclusively breastfeed or good to provide other liquids soon after childbirth. Third, for care seeking for childhood illnesses, there's a heavy reliance on pharmacists, chemists, and proprietary and patent medicine vendors. Again, we see variation across states. So these low levels or this heavy reliance on the PPMVs tells us that a lot of children are not getting the rapid diagnostic tests to test for malaria or appropriate use of antibiotics for ARI or ORS and zinc for diarrhea, which, as we know, are all very effective measures for treating childhood illnesses. And so all of these practices are contributing to an atmosphere that inhibits better health. We also know from the data that the poor are many times less likely to use services than the non-poor. So for many services and behaviors, there's what's done by the top 20%, and then what is done by the rest. So the poor, for example, are only 1/7 as likely to make 4 or more ANC visits as the non-poor. They are 1/8 as likely to deliver in a health facility, and they are 1/3 as likely to use postnatal care. So depending upon the indicator, the top 20 to 30% are doing much better than the bottom 60 to 70%. So similar to the data on practices, we find valuable information about various myths that may inhibit behaviors. Again, all of these are statistically significant in ideational regression models looking at behaviors. So for example, over half of women across all 3 states agree or are unsure that vaccines have chemicals that are dangerous to children. So it's hard to imagine that a majority of children are going to be vaccinated if a majority of women think that vaccines could be dangerous. As another example, just over 50% of women believe that only weak children die of pneumonia. So that obviously means that a lot of children, those not perceived to be weak, are at risk if families do not correctly understand the risks of common, potentially fatal childhood illnesses. And then there's a clear perception by many women that most ANC services are not necessary. And as we said earlier, that colostrum is bad milk. We looked at barriers and influencers. And so the data look at reasons for seeking care at different types of providers and perceptions of quality care. So this is just one example looking at pediatric diarrhea care seeking at government hospitals, government PHCs, and pharmacies, chemists, and PPMVs. So the number one reason for choosing providers across all providers was trust, cited by over 40% of respondents across all three providers. Note that we're not saying that only 40% of respondents trust these providers, rather 40% cite trust as the main reason for choosing a particular provider. So for more numerous providers, such as government PHCs and PPMVs, proximity seems to be an important factor, less so for hospitals that are higher level care and therefore more difficult to get to. That providers provide effective treatment is also a common reason for choosing providers, more so for PHCs than for the other two. And respectful care is more commonly cited as a reason for choosing hospitals, where you would expect you would get higher quality care than for the other two. So a slide that looked at people who chose to use services and the reasons why they chose to use services. And this is a slide about people who chose not to use services. And there was an abundance of those. So amongst non-users of services, questions were asked about why they chose not to use services. And these were multiple response answers. So people could highlight several reasons, and there were some very clear patterns. So for pregnancy-related services, for example, there's a clear norm against those services. 2/3 of women who didn't deliver in a facility didn't feel that it was necessary. The same was true for 42% of non-users of ANC services. So shifting this priority is a clear programmatic, so shifting this norm is a clear programmatic priority. Spousal opposition was also a common reason for non-use across a wide variety of behaviors, including nearly 1/3 of women who did not exclusively breastfeed, and 1/3 of women for whom their child was not given all vaccinations. So working with spouses to address their reservations is also a programmatic priority. Price was a barrier for curative care more so than for other health services, perhaps related to greater uncertainty regarding the costs of treating illnesses relative to pregnancy-related care, where the price may be more predictable. So it might be useful to study just how responsive people are to changes in prices for different types of health services. Fatalism is also a barrier. Health outcomes in many cases are believed to be up to God, and so BA's work with religious leaders as part of their advocacy core group model may help to address that barrier. And note that proximity does not seem to be a significant barrier, which is good, with the exception perhaps for childhood vaccinations. So this slide presents data on who influences decisions for different types of behaviors. And the dark blue bars represent decisions that women can make on their own without outside consultation. And you can see there's considerable variation in how much autonomy women have. So for example, the majority of women are able to make decisions on their own about family planning, but there appears to be lesser autonomy for the other behaviors. That's not necessarily a bad thing, as BA is heavily focused on increasing conversations amongst couples about health issues. So what we can see with the bright blue bars is that husbands clearly have a strong influence on a variety of behaviors, particularly for child-related services. So 80% of women say that their husbands influence the decision for care seeking for sick children. Now keep in mind that our survey question on influence was neutral. Who influences your decision to do X? So this influence could be either positive or negative. And we saw on an earlier slide that husband's opposition was a key barrier to use of services, but we'll see on the next slide that on balance, husband's influence tends to be a positive thing. So this slide looks at the use of forced services as a function of whether or not a husband influences that decision. And you can see that in general, husband's influence is positive, and in some cases strongly positive. So the dark blue bars represent utilization by women whose husbands influence the decision, and the light blue bars represent utilization by women whose husbands don't influence the decision to engage in that behavior. So for example, children whose fathers influence vaccination decisions are 1.4 times more likely to get a measles vaccination and 1.6 times more likely to get all 3 DPT vaccination. For women whose husbands influence pregnancy-related care, they are 20% more likely to attend 4 or more ANC visits and 60% more likely to deliver in a facility. So on balance, what is the takeaway? That husband's influence appears to be a positive factor. As I said before, BA is encouraging greater dialogue amongst couples. So the positive influence of husbands is supported by this slide as well. So we asked, have you ever talked with your husband about using modern contraception? And then related it to 3 family planning outcomes: current use of modern contraception, intention to start amongst non-users in the next 6 months, and intention to continue amongst users in the next 6 months. So among women who have never had a discussion with their husband about family planning, not surprisingly, only 3.4% are currently using, only 10% intend to use, and 50% intend to continue. So you might ask yourself, how will this differ for women who have actually had family planning discussions with their husbands? Well, the differences are quite dramatic, as you can see. Women who had such discussions are 11 times more likely to be currently using family planning, 5 times more likely to intend to start, and 50% more likely to intend to continue. We can't necessarily infer causality from those relationships, but there's clearly a positive link of some kind between discussions of family planning behaviors and intentions. So we ran mixed effects logistic regression models controlling for a number of things: age, education, wealth, occupation, state of residence, and our outcome variables were the priority behaviors. And the advantage of regression analysis is that it allows us to tease out the independent effects of key ideational factors such as knowledge, beliefs, self-efficacy, and norms, holding constant all other things that could affect those outcomes, such as differences in education or income or state of residence, and so on. So from that, we can identify which ideational factors are likely to serve as the strongest levers in achieving behavior change. So this first slide looks at making at least 4 ANC visits as a function of knowledge, self-efficacy, and beliefs. And this figure presents predicted probabilities or estimates of the likelihood of a behavior occurring, adjusting for control variables and ideational factors. So for those who have the knowledge relative to those who do not, or for those who have self-efficacy relative to those who do not. So for example, a woman who is able to report any health benefit to herself from ANC was 3.2 times more likely to make at least 4 ANC visits controlling for other factors. A woman who knew to make at least 4 ANC checkups was 2.1 times as likely to make 4 ANC visits. And women who were confident that they can get to a facility are 2.5 times as likely to make at least 4 ANC visits, and so on for other ideational factors. So what is this actually telling us? Well, it's telling us which levers BA can pull, such as knowledge and self-efficacy, to have the largest effects. Knowledge and self-efficacy are clearly going to have important effects, and if BA can improve these indicators, then they can improve ANC use by many multiples. We did the same thing for facility deliveries, and here women who have confidence that they can get to a facility are 3.4 times more likely to deliver in a facility, and women who agree that a health facility is the best place to deliver a baby are 2.6 times more likely to deliver in a facility. And now you might say, well, so what? It seems rather intuitive that if a woman believes that a health facility is the best place to deliver, then she'll be more likely to deliver there, but that's not actually what we're saying. And the point is, if SBC programming can convince women and couples through messaging, through home visiting, through community dialogues, that a facility is the best place to deliver, then they could increase facility deliveries by 2.6 times, and that is a very effective program. So making use of the regression models that we've referenced, we looked at what could happen if BA achieved a world of perfect knowledge or perfect ideation. So if people held all positive norms, had perfect knowledge of the benefits of services and behaviors, and felt fully confident that they could get to a facility. So these are the adjusted likelihoods of making at least 4 ANC visits by a wealth quintile. Again, you see the big differences between the highest quintile and the lowest quintile. Now, suppose we had a world of ideal knowledge. So everyone knows the health benefits of ANC. Everyone knows to make at least 4 ANC visits. And we saw those had positive effects on the earlier slides. So overall, that would increase the percentage of women making at least 4 ANC visits by about 50%, from 23% to 36%. And the effects would be even largest in the poorest quintile. So notice in the second poorest quintile, ANC use would almost double. So now suppose we had perfect ideation. Every woman is confident and all norms are favorable and there are no myths. In that scenario, overall use would increase by over 100%, from 23% to 55%. Again, the effects would be largest amongst the poorest. In this lowest quintile, increasing from 11% to 50%, indicating that these lower quintiles are areas where there's likely to be the biggest bang for the buck. We did the same for facility deliveries again. In this case, there were measurable effects for knowledge, increasing overall facility deliveries from 16% to 21%, but the largest effects were for self-efficacy and beliefs and other ideational factors, which when increased would more than double facility deliveries from 16% to 37%. So there are 2 key takeaways here. So first of all, SBC has strong potential for effects. And second, SBC is not a miracle. Even if it improved all components of the strategic communication framework, there's still going to be a lot of work to do. So 63% of women would still not be delivering in a health facility, meaning that there are other things that need to be addressed that are outside the realm of SBC. Okay, so I'm going to turn things back over to Dele to talk about the programmatic implications and the next steps.
Thank you, Paul, for that interesting presentation. So I'll briefly, quickly on the implications of this results, and then the next step, and then Emily will come and respond to all of the questions that we have in mind to ask. So what are the implications of the findings that Paul has so brilliantly presented? And I also want to indicate that it's just the tip of the iceberg that we are presenting here. We will not have time to accommodate even 25% of the outcome of the study. Now, our outcomes are low amongst most women, but even lower amongst the poorest and least educated. Husbands play important roles in decision-making across health areas. We need to have robust evidence about male ideation and behaviors as there changes over time. Is critical to understanding behavioral model. Also, there is a clear need to address misconceptions that hold back progress in these health areas. Women value convenient, trusted, and effective care in choosing treatment locations, underscoring the need to improve health services. Next slide, please. The implication of this analysis that we have done is that evidence from the baseline suggests that improving an array of additional factors will have large impact on antenatal care, facility delivery, and other health behaviors. There's also the need for conjoint efforts to improve healthcare quality and perceptions of healthcare quality. Also, awareness and beliefs about treatment efficacy are priority to address. Also, the inaccurate risk perception about illness severity and susceptibility leads to underuse of services. So these are the things that programs we want to look into as programming is done to address what we have found. Next slide, please. The next step, what next after this? The next step is that we will be disseminating a lot of the PSS finding via webinars till September. We'll be discussing the thematic areas, ANC, diarrhea, breastfeeding, and we also invite you again to come and participate in the discussion around these areas. We'll conduct index analysis into BA SBC program. This one is ongoing and in collaboration with Breakthrough Action. We would like to focus the results on key areas of interest in the breakthrough programming area. We will examine associations between ideations and behaviors for MNCH and nutrition, malaria and family planning, preparing research briefs. We have almost completed all of these slide decks and the manuscript for publication. There'll be other program relevant, e.g. income inequalities, the impact of inequality on some of these additional and behavioral factors that has been discussed, spousal communication, differences between doers and non-doers. We will prepare a midline. We are already preparing a midline survey that we mirror on this baseline survey that we are presenting. Next slide, please. Future work is that the BSS baseline is the first phase in assessing the effectiveness of integrated versus malaria-only SBC programs. BSS will also contribute to cost-effectiveness analysis of integrated versus malaria-only SBC programs, and BSS will also be linked to program monitoring data to examine localized impacts, e.g. the HC3 program impact of family planning behaviors and ideations. BSS will be linked to health facility database, for instance, the kind of database that IHP has to examine demand and supply side factors in health services use. At this stage, while I want to thank the presenters, I want to hand over to my colleague, the Deputy COP of Breakthrough Research, Dr. Emily Johansen, to address some of the questions that you may have so far in this presentation. Emily, welcome on board.
Hi, Deli. This is actually Sherry. Emily's having a little bit of difficulties right now, so I'm going to moderate for her. So apologies. I'm in the DC office working with the Population Council on Breakthrough Research for the audience. So we have a couple questions, and because of time, we thought we would just ask these two, and then because they're related, and then we should close. So from Tunde Segun, I thought that most of the states, especially up north, claim that they offer free MNCH services. So how come cost is an issue in your findings? And then related to that, from Immaculata, was out-of-pocket expenses for consumables seen as a barrier to increase uptake of MNCH services in primary health facilities?
Okay, thank you very much, Dr. Shegun. The cost that this study picked up can best as hidden cost. In this region, PHC services are not used a lot because, like I often say, that there are what I call private markets around PHC services, but the protocol is not designed to pick out these private markets, and so instead of the cost that the government, the cost schedules of the government, those ones may not be available to the patient. but all what the cost, the private sidebar cost that comes to them. And it may be affecting patronage of the PHCs in this region. And particularly that may be another cause why they just go straight to the pharmacy. I know in the past, patients have complained that, look, when they go to these hospitals, these clinics, they just give them a prescription to go and buy. And so why don't we just go straight to the pharmacy? So they are hidden costs. They are not in the formal cost schedules as provided by the provider, that government as the provider. But it should be instructive that the study picks this cost thing out. I hope I addressed.
Yeah, can I just add, when you look at the slide for reasons why people chose not to use services, cost didn't seem to be a particularly important barrier for the MNCH services. It seemed to be a barrier much more for the curative care services. There obviously still are hidden costs, but I don't think that those are the level of impediment for MNCH services that they are for some of the other services. And I'm sorry, what was the second question?
The second question, Sherry, can you kindly remind me of what it is?
Yes. Was out-of-pocket expenses for consumables seen as a barrier to increased uptake of MNCH services in primary health facilities?
I think Paul's response now just addressed that. Cost issues did not affect MNCH services as the other curative services. So it's not picked as a barrier in itself.
The other thing is our data are their demand side in the sense that we are collecting information on the user of health services, but we don't necessarily have complete data on all of the aspects of the supply side, including we don't know exactly how much they paid for services or what they were charged or what are the official prices. And so that would be necessary if we were going to do a complete economic demand analysis. And so that might be interesting to look at if we were to be able to link our data with facility level data that included measures of quality, service availability, and importantly, price.
In addition, you see, as we mentioned as the next step, IHP has some huge data on the supply side. And we from the same region where we did this study, and we are looking to hook this data together and pursue both demand and supply side analysis. We might be able to pick some of these things up, but albeit in probably softer modes, because the studies were not, as Paul has said, designed primarily to pick up these issues. Any more questions?
Do have one more if we feel it's okay to go a little over. So from Toluwolope, sorry if I'm killing the names here. How comparable in terms of ideation and socioeconomic factors are the sites from which respondents were surveyed?
There are variations across all of the states in terms of socioeconomic status. I mean, they're comparable in the sense that, yes, there are poor areas in each state and areas that are not as poor in each state. We created a wealth index, which was made as the standard DHS procedure is, a wealth index constructed from what assets households own, tables, chairs, cars, things like that. They're comparable in the sense that we are looking at the same set of assets for people in each of the states, in each of the surveyed areas. If you look at the survey the baseline survey report, we have much more in the way of detailed comparisons across states, and that would certainly give you a sense of the differences in the characteristics, education levels, things like that across the different states. And then, of course, the health behaviors as they differ across the states.
Yes, thank you very much, Paul. Thank you so much to our presenters for leading us through the slides. We're about 6 minutes beyond time, but I think it's been worth every minute listening to some of the findings and the implications for programming and the next steps. So I don't know, but I saw that a few people in the chat box had requested for the slides as well as the technical report. So I probably would want to commit daily to maybe sending out stuff to the invitee list after this so that people have access to those documents. And then just to encourage to say thank you so much for taking the time and staying through till the end. We hope that you've been able to learn a thing or two, and keep the conversation lines open. I guess since we have the contact list, we'll continue to reach out and invite you for more health area specific discussions in the coming weeks. Thank you again so very much, and we hope that you found this as useful as we have found it. Thank you. Over.